All right, welcome to another episode of ICU Doc Talk. This week we're going to talk about brain death. Um, Brain death is something that is very poorly understood by people outside of medicine, even by people inside of medicine. The confusion is endless. I've made a lot of TikTok videos about it, and it's confusion with no end. So I'm really going to get into it, what it is not, and what we do about it. So here we go. Okay, so let's talk about different organs of your body. We're just going to zoom out here for a minute. So you have different organs, right? You have a brain, you have a heart, that's basically a pump. You have kidneys that helps filter your blood and have good blood pressure regulation. Your kidneys are involved with electrolyte balance, a lot of stuff like that. Your liver is a vital part of your body. It processes what you eat. It packages it up and it shuttles it to your body so that it can actually be used by your cells. It's also vital for creating blood clotting factors. It does a lot of stuff. You cannot live without your liver. You have what else do you have? You have your adrenal glands. They sit on top of your kidneys. They make what we call steroids, mineralocorticoids, and which help regulate blood pressure and a lot of stuff that has to do with metabolism. They produce epinephrine and norepinephrine and dopamine for your body. Vital function, right? What else? You have your GI tract that helps process food. It breaks it down, digestive. You have a whole microbiome there. So what I'm trying to get at is you have many different organs, and most you need them or you die. Your organism dies, right? Your liver, you have to have a liver. You cannot live without a liver. Kidneys, you have to have at least one kidney. If you go into kidney failure, you can live on dialysis, but that's doing the function of your kidneys. So the organism cannot live without kidneys. Heart, obviously you need a heart or you die. There's some things you don't need, like a spleen, right? So the spleen helps with filtering blood. It removes old and damaged red blood cells. It also helps fight germs that are invading your blood system. But you can live without a spleen. Like if you get in a car accident and your spleen gets damaged or you get shot by a gun and it needs to be taken out because it's bleeding to control the bleed, take it out, and you're usually pretty good. There might be some infectious organisms that you're not so good at fighting anymore, but you can live without your spleen. Your appendix isn't really an organ. That's just like a vestigial little closed little pouch at the end of your one of your large intestine. You don't need that. So that's not even an organ. There are some things you have to have in your body, and there's some things that you can be removed, like your gallbladder, that can be taken out, and you can live with. What's my point here? So there are many different parts of the brain. There's the upper hemisphere of the brain, the cortex, which is like all of your motor control and your speech and your vision and your executive function. All of those, like the prefrontal cortex, the occipital, all of those things that have to do with those things. Now, and you can knock out one of those things in a stroke, right? Someone can go blind, but you're not going to die, right? Or someone can have a brain bleed that takes off the system of their brain that makes them be active and awake, that wakes you up, and that can go out so you're asleep and you're in a coma, but your brain is still functioning. You're still alive. That doesn't kill the organism. So there are certain parts of the brain that if they get damaged and if those cells die, the organism will die. The whole body will die. The part of the brain that you cannot live without if it's damaged is the brain stem. Okay? That's really what we're talking about with brain death. It's the brain stem. So the brain stem is the lower part of the brain, and it connects between the upper part of the brain and the spinal cord. It's part of the central nervous system. It's responsible for regulating most of the body's functions that are essential for life, like breathing and your heartbeat and controlling your nervous system, all those functions, and even causing someone to be awoken, and all the cranial nerves, the nerves that go to your eyes and your tongue, all the nerves of your face and mouth. It controls all of those. It's an essential part of your body. You must have the brainstem to live. Brain death is when there is some sort of intracranial inside of the skull, some sort of injury, whether that is traumatic injury or whether that's a brain bleed that has caused irreversible injury to to the brainstem and the whole brain. That is irreversible and you cannot come out of it. That is what brain death is. Death, according to the Uniform Determination of Death Act, the UDDA of 1980. This proposed a legal definition of death, which is widely accepted. This is a quote from the act. An individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. So when the brain and the brainstem have swelled and there's now limited blood flow and they swell to the point that there is now irreversible neurological injury that you cannot recover, that is brain death. The unique thing about brain death, as opposed to traditional death like cardiac or respiratory arrest, is that the rest of the organs can still continue to function and the body can still appear as if it's alive despite the brain being dead. That, of course, is where all the controversy about brain death comes into play, and that is where all the confusion about brain death comes into play. I once had a patient, a young woman, who was jet skiing or something like that. Very young woman. And she suddenly collapsed and she was brought into the hospital and she had a cerebral aneurysm. An aneurysm is where you have a weakened, like, outpouching of a major vessel or any vessel. And this one was in the brain. Some people are just born with cerebral aneurysms. There's just the wall is weakened. It kind of pouches outward when it shouldn't. It should be like a nice straight pipe. So she had an aneurysm that she was undoubtedly born with she didn't know about because nobody looked. Why would they? And that burst, maybe while she was exerting herself. And then she had bleeding around the brain, which is called a subarachnoid hemorrhage. And that's a type of stroke. And when you have such profound bleeding around the brain like that, it can cause what's called a vasospasm. It can cause the blood supply to your brain, to the remaining blood supply, the vessels to spasm up because they're irritated because now they're bathed in blood on the outside of the vessels, which they normally are not. And then that can cause further stroke or ischemic time. Ischemic means, dying tissue that's not getting blood flow. And then that further vasospasm is just like a runaway rail where the brain cells themselves start to die. She quickly progressed to brain death, despite a very appropriate interventions by neurology and even interventional neurology. And so this is a very young girl and teenage girl, and now this is when I was a resident, and it was like 2 a.m. and finally all of her family had arrived from out of town. This was like 15 people in a room, and I was a resident, and I was covering an enormous neuro ICU alone, right, with my attending at home, which was what our model is and was. And I had to sit there and explain to a family of 15 that their daughter or cousin or sister was dead, despite the fact that they had just been in her room, and if they felt that her hand was warm, and that maybe she even moved a little bit. Maybe she moved. And they can feel her heartbeat, and they can even see that there's normal vital signs, like pulse ox is 100%, heart rate's totally fine. They sit there, they witness all these things, and then they have some young, Doogie Howser-looking doctor, resident, like myself, who's telling them that their daughter is dead. Just imagine you're in that room, and imagine how a random group of 15 people is going to take that about their loved one who's this young, amazingly young, impossibly young person. Just imagine how 15 randomly selected people are going to take that news. Are they going to accept that? Are they going to even understand this concept? And then now imagine that they are imagine they speak a different language than I speak, that I'm using a translator. Imagine they come from a different culture that I and most of the hospital staff come from. Imagine that they have a different religion than everybody else has that's taking care of the patient. Imagine all those differences then compounded on top of that. That would further result in complete confusion, misunderstanding, that would then sow a lot of distrust about what is going on. That is just the beginning of how complicated brain death can get. So let's get into a little bit of the nitty-gritty of brain death, how it's diagnosed, and where we go from there. So in most adults, trauma, getting hit in the head, or a subarachnoid hemorrhage, which is what I just mentioned, they're the most common events that lead to brain death. There's other things like an intracerebral hemorrhage, which is another type of stroke where you just bleed within the brain organ itself. Hypoxia, which, bad blood flow to the brain and just being hypoxic for whatever reason. Say someone has a cardiac arrest and they're down for a while, and then we get their cardiac arrest, then we get their heart back, but their brain had a bad flow and it was hypoxic, and then they go brain death from that. And then also just an ischemic stroke, which is another type of stroke, which is like an embolic ischemic stroke, where there's like a blood clot. Anyway, just another form of stroke. Any condition causing permanent widespread brain injury can lead to brain death, basically. Now, I want to touch on, so we've talked about a little bit what brain death is. It's irreversible neurological injury to the whole brain and the brainstem. You cannot recover from brain death. The patient is dead. Legally, they're dead. And I just want to talk about what brain death is not. It is not a coma. It is not a persistent vegetative state. And it is not locked-in syndrome. Let's just talk about those three things real quick, about how they're different. A coma, persistent vegetative state, or locked-in syndrome. Let's talk about those three things. So a coma is like a clinical state where a person is unresponsive to like stimulus, to someone talking to them, or to physical stimulus, like trying to get a sternal rub, trying to get someone to wake up. They're either difficult to rouse or they're unarousable, and it's either we cause the coma with drugs, right, intentional like sedation, or a patient is just not alert, they're not in their normal state of arousal, or they're obtunded because of some sort of disease process that is causing them to be in a coma or comatose state. The word coma is a really non-specific medical term, and to be honest, coma we usually don't actually use in the medical world all that much because it's so vague, and it's been kind of a word from Hollywood. It's not from Hollywood, but Hollywood tends to use that word coma, like they're in a coma, or maybe non-medical people tend to use it more because it's so imprecise. I rarely, when I'm communicating with colleagues in the medical field, I rarely say they're in a coma because it's so extremely vague. It does not give you enough information. Someone can wake up from being in a comatose state. They can be on no sedation and be in a comatose state, and maybe their disease process gets better. Maybe they have brain swelling or whatever it is, and that gets better. Someone's cranial nerves can still be intact if they're in a coma, and it's something that can be reversible. So if you hear someone is brain dead, they're just in a coma, these are completely different things. Being brain dead is not the same thing as being comatose or in a coma. So, and then a coma, it needs to be distinguished from a persistent vegetative state. So PVS, persistent vegetative state, is characterized by unawareness, but these patients can have normal sleep-wake cycles and even can be arousable. Patients in a coma, they may progress to a vegetative state. Meaning, so if someone's in a coma and has brain injury, like TBI, traumatic brain injury, and they're comatose, they can progress to a persistent vegetative state, meaning they never have an overall improvement in their function or their outcome. Their outcomes just never improve. Now again, coma and persistent vegetative state must be distinguished from brain death and locked-in syndrome. These are different things. So persistent vegetative state can be wakefulness, but without awareness. It can represent a transition between coma and recovery, or between coma and death, if someone eventually dying of it. The persistent vegetative state is what you think of like someone who has had brain injury and they come out of like their initial insult to their brain, but they have permanent brain damage. They may not be able to communicate. and they're not aware of what's going on, but they can breathe on their own. Their vitals are on, they can support themselves on their own, perhaps. Maybe they need a tracheostomy and they need low-level ventilator support. Maybe they probably need a feeding tube because they can't control their own secretions. They can't swallow, things like that. So persistent vegetative state is generally characterized by someone who can be awake, is maybe not aware, and is not able to care for themselves. But they're not brain dead, right? Obviously they're not brain dead. Other things that kind of characterize it is no evidence of sustained, purposeful, or voluntary behavior, and as a response to visual or auditory, tactile, or painful stimulus. There's no evidence of language comprehension. They don't express language. Intermittent wakefulness manifested by the presence of sleep-wake cycles, like I talked about. They can have, as I said, sufficiently preserved brainstem autonomic function. Their nervous system is still intact, and they can survive, with usually with medical and nursing care. They can also have like bowel and bladder incontinence. And as I said, their cranial nerves and their spinal reflexes are typically intact, or they're variably preserved. So that's persistent vegetative state. It is not brain death. Okay, so that brings us to locked-in syndrome, which is very different from everything I've just discussed. So locked-in syndrome is a catastrophic condition. It's caused by a stroke of the brainstem, but not of the entire brainstem. It causes a stroke of like the muscle neural path, the pathways that affect muscle control. It just takes them out. It wipes them out, so that a person becomes paralyzed. They become like quadriplegic, and they can't use those muscles anymore. But they are aware. They are aware. They are awake, and they are most definitely alive and not brain dead. Those are the basic characteristics of locked-in syndrome. It's retained alertness and cognitive abilities, and then a paralysis of the limbs, and paralysis of oral muscles. And so a person can't speak. They just sit there. They're locked in. They're basically in a, kind of a straitjacket within their own bodies. They cannot move, but they are fully aware. Now, how do we know that these patients are locked in? They can still communicate. Oftentimes, so they're not completely paralyzed. Not all of their cranial nerves are paralyzed. They often can still blink their eyes, and that is how they communicate. That's how you figure out that the lights are on and that they are there, and that's how they interact with the world, by blinking and communicating that way. And they can see, right? They're not blind, typically, right? So their senses are still intact. They can perceive their environment, and they can communicate that way. And then, kind of like persistent vegetative state, these are patients that cannot breathe on their own. They cannot eat on their own. They need a feeding tube. They need a breathing tube, a tracheostomy to live. And they obviously need very intensive care to sustain their lives. So that's locked-in syndrome. Okay, so we just reviewed coma, persistent vegetative state, and locked-in syndrome. None of these are brain death. All of these people are alive in varying states of arousal and wakefulness. And when we're talking about withdrawing care, let me back it up. So when someone has brain injury, whatever, in a general sense, whether they're comatose or persistent vegetative state or locked-in syndrome, a family member doesn't need the diagnosis of brain death to stop care. Okay? So someone who's locked in, them or their family members may choose to stop care so that they pass away peacefully in a natural way, and it's not sustaining their life. You don't need to be brain dead to make that decision. You don't need the diagnosis of brain death. I know that might be obvious, but that needs to be said in this conversation. You don't need to pursue even if you think someone's brain death, you don't need to do an exam and a diagnostics, which I'm going to talk about with brain death, to then say, we're going to stop care and let my loved one pass away. So at any moment, persistent vegetative state or locked-in syndrome, if we're sustaining those people's lives, it's because their family members have made an active decision to preserve their lives. And it's perfectly acceptable to stop care and move towards comfort care and let them pass away naturally, which would be pretty quick, or to pursue care. That is the prerogative of the family member, and the loved one that's there, advocating for the patient. Okay, so let's go delve more into brain death. How do we distinguish brain death? How do we diagnose it, and how do we know that a patient is brain dead? Because we got to be confident in that decision making, right? Because when we declare someone brain dead, Then we talk about them being an organ donor, and because their organs are still alive, and then and I'll talk about it more. But then we procure those organs from that body, while we're keeping the body alive, the organs and tissues alive. So we have to be very confident in this decision making and diagnosing brain death. So how do we diagnose brain death? Let's talk about it. So the first thing to keep in mind when you're diagnosing brain death is there are a couple of things that are going on in the clinical setting that you need to be aware of. So there needs to be clinical or like neuroimaging evidence that there's been catastrophic central nervous system failure that's compatible with a clinical diagnosis of brain death. So what that, meaning like things need to match up. Be like, okay, they had a traumatic injury, they had a stroke, and now they're not waking up, et cetera. So things need to start aligning. Brain death doesn't just happen out of the blue. There needs to be a cause, a known cause. And then you have to exclude any complicating medical conditions that can confound your assessment. What I mean is like, okay, someone, as I mentioned, someone can have a coma for different reasons, right? You can have electrolyte disturbances, like severe electrolyte disturbances, like your sodium, or your BON, your uremia. You can be really uremic. Those can be out of whack. You can have acid-base disturbances. You can have other shock, like an ongoing shock state. You can have delirium. There's other disease processes that can mimic, a cause of coma. So those have to be ruled out. They can't be confounding your clinical assessment when you go to assess someone for brain death. With that, you can't have any like acute drug intoxication that's going on, like, any sedative medications, right? We give lots of sedatives, propofol and midazolam and Dilaudid, and there's many, many different sedatives. Those have to be out of the system, out of the body. You have to make sure hours and hours, days and days, maybe not days and days, but a lot of time has passed to make sure that those have been broken down, excreted from the body, and that they're not intoxicated from like illicit drugs, alcohol, methamphetamine, whatever it is, or sedative, I guess, more sedative medications. And then you got to make sure they're not acute poisoning is going on. Rule out that they didn't take a whole, bunch, accidentally get poisoned with something, intoxicated with something. You have to rule all those things out. And you got to make sure that they're not hypothermic, like profoundly hyperthermic. The core temperature needs to be above 36 degrees centigrade. Because hypothermia, again, can confound your assessment of brain death. So you have to make sure those things are not going on. Another thing is the blood pressure needs to be, the systolic blood pressure needs to be over 100. And it's okay if that requires some vasopressor support. One thing that can happen and also can confound this is you can be in neurogenic shock from a central nervous, from being in brain death, meaning your nerves, as the brain starts to die and the brainstem starts to die, your nervous system can go into shock, and it may not support your blood pressure as well. And sometimes that does. Often it requires vasopressor support. But that doesn't mean you're in a confounding shock state. Anyway, that obviously can get kind of nuanced pretty quick. Okay, so you've ruled out all these confounding factors, and then you go to do a neurological examination. Now, different states have different, I think, laws about who can actually do this examination, but it's generally a critical care doctor, and it's generally a neurocritical care doctor. I am not a neurocritical care doctor. I do have experience in neurocritical care, and I do work to a limited extent in neurocritical care, but I'm not a neurocritical care doctor. So I'm not technically the one that does these exams. Although I think I can get certified to do it. I haven't really looked into it, but I don't need to because my institution has these. Anyway, so a neurological exam, it's usually a neurologist, but it doesn't have to be. It doesn't have to be. So you must demonstrate the following things, and it's a list that I'm going to read. So you have to demonstrate that they are comatose, that they have an absent motor response that originates from their brain and not from their spinal cord. Okay, your spinal cord reflexes are still intact when you're brain dead. Let me just back that up. So when you go and you accidentally touch a hot stove, you pull your hand away right away, right? And that is a spinal reflex. What that means is there's a nerve arc went from your fingertip, it sensed that heat, and then that signal went to your spinal cord, and it got processed there. And then that sense nerve turned around into your motor nerve, and it pulled your arm away without your brain processing it. Think about how significant that is for a moment. That's what a spinal reflex is. A reflex is something where your brain doesn't need to give the go-ahead for your body to respond, right? So when you pull that arm away, obviously your brain processed it and you understood, oh, I pulled that away. But you started to pull that away before even realizing what was happening. And so you can still, the spine is control of those reflexes. You can still have spinal reflexes with brain death. Okay. The next thing, in neurological exam, absent pupillary light reflex. Your pupils, you don't have that reflex anymore because that's a cranial nerve. Cranial nerves, if you remember, originate from the brainstem. The brainstem is dead in brain death. So your cranial nerves won't work. That includes absent corneal reflex. That's where the cornea, right? There's a corneal reflex that you touch someone's cornea and you blink. That's coordinated by your brainstem, not your spine, right? So the cranial nerve reflexes go away, but whereas the spinal reflexes stay intact. You have an absent, it's called a oculocephalic reflex and an oculovestibular reflex. This is done by something called caloric responses. It's also, there's a maneuver called doll's eye that you move the head back and forth to look at this reflex. And then there's caloric testing to look for the stimulus. I won't get too much into that nitty gritty, but it's a test you can do. You have an absent gag reflex. That reflex, again, is not controlled by your spine. It's controlled by your cranial nerves. You have an absent cough with tracheal suctioning. No, they don't cough. And then you have apnea. Person is not breathing because the breathing reflex, which maybe it's not right to call it a reflex, breathing is mediated by your brainstem, not by your spinal cord. This is why, this is really painting the picture why brain death is death, because you cannot live without these reflexes, right? You can't live without breathing. Anyway, so the reflexes that can be intact during neuro assessment that are intact from your spinal cord, you can have fingers that are moving. You can have your neck that has reflexes intact. You can have something called triple flexion, which is flexion at your hip and your knees and your ankles. When you stimulate the foot, that's testing for Babinski sign. You can have your toes can move as well. You can have your upper arms moving, going in and out with your forearms. You can have widespread muscle fasciculations of your extremities in brain death. So, and this is why this is so hard for families to understand. They can be at their bedside and they can be like, my daughter held my hand. I felt her hold it. I felt her, close her fingers around my head. She's not dead. No, she is dead. Those are just the spinal reflexes that are just kicking in. The brain is dead. I know that sounds cruel, the way I'm even saying it, but it is the truth. Okay, and so once the other criteria have been met for brain death, meaning your neuro exam, you're finding that all the cranial nerves are not working, they're not waking up, you've ruled out all these other confounders like drug intoxication, all those things. Then you do an apnea test. There's just standardized procedures for doing this. You basically, and what an apnea test is, you turn off the vent, you see if they breathe. Basically, in essence. Again, they have to have a good core temperature. They have to have a blood pressure greater than 100. They have to they can't be hypercarbic. You have to have the CO2 concentration in your blood needs to be 35 to 45 millimeters of mercury. It can't be up. You cannot be hypoxic. Your volume status has to be normal. The test is not valid in patients who have chronically high carbon dioxide, like carbon dioxide retainers, like with COPD. You can't have any muscle paralysis on. You can't have any high cervical spinal cord lesions, things like that. In a positive apnea test, there's no respiratory response with a PCO2 of greater than 60. What that means is you turn off the ventilator and you let their carbon dioxide build up. You're not breathing for them. And if someone has a carbon dioxide greater than 60 in their bloodstream, that is highly stimulating for someone to breathe, right? That is actually what stimulates you right now to breathe is carbon dioxide. And if that is built up in a person and they're not breathing, it's because their cranial nerves are dead. It's probably because they're brain dead. That's why this is diagnostic. It's called the apnea test. Now, with a apnea test being positive, or I guess negative, whatever you call it, meaning they don't breathe, there's a lot of times typically an observation period. It can vary 24 hours, 48 hours to observe them to see if there is any brain, central nervous system brainstem activity or cerebral activity. And that can vary from institution to institution. And as I mentioned, the expertise of the people, the physician making this exam to make the diagnosis of brain death, it varies by state and by country. There's some states that require a physician to be a specialist in neuroscience, like a neurocritical care doctor. Other states give authority to nurses with certification by a physician to do that. I'm not putting a value on that. What's good, what's bad. I'm just saying it does vary. And then some countries and states differ on whether it should be one physician is required to certify a patient, or if it's more than one, if it's two. That varies across, where you are. Now, I think this variation is where a lot of problem comes in. Okay, so I can't stress it enough. Brain death is death. If it is diagnosed properly, the patient is dead. No, I guess that's not the right way to say it. Brain death is death. However, if someone who's not experienced and is not doing this correctly, they could misdiagnose brain death, meaning the patient's not brain death. Maybe they have persistent vegetative state or something like that. So the variation and the lack of standardization across like all of the United States or from country to country probably results in the misdiagnosis of brain death. And then so what happens is you have a family member in a family, they get labeled as brain death, and the care team is like, we should withdraw care, and the family's like, no, 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 no. And then 3 days later, the patient starts to wake up. And then that gets sensationalized in the news. And then they're like, oh, they said they were brain death, and then the public starts to believe that brain death is not a thing, and then becomes very skeptical of the diagnosis of brain death. I think that's where that originates. There was a survey of physicians at 3 academic medical centers. They identified 68 respondents who performed brain death evaluations. Nearly 1/4 had no training in the examination of brain death, and only 25% reported doing an evaluation consistent with practice guidelines. So that's just one study, but that's a problem right there. Okay, that's why it gets misdiagnosed, right? That's a problem. Another really, really crucial point about all this, there's a requirement, or it's a recommendation in some place. The person who's doing the brain death examination cannot be like a physician or a team member who's involved in any organ donation process. The examiner should not be the same physician or surgeon who's part of the transplant team, right? Because that's an immediate conflict of interest, right? So that would be totally unacceptable. These are different teams. It's not like one person's making the brain death examination. They're like, all right, I'm going to take them downstairs, and now I'm going to procure their organs. Sorry, I almost said harvest, and I apologize for that. I won't edit that out because harvest is the bad word. You should not use the word harvest organs. It has very terrible connotations. Procure organs from a brain dead donor. That brings us to the topic of brain death. That brings us to the topic of organ donation. Okay. Real quick, I did forget to mention that the neuro exam and the apnea test could be confounded. Sometimes the cranial nerves can't be totally examined. There is neuromuscular paralysis. There's heavy sedation still present. The apnea test has to be aborted for some reason. There's all these confounders. So there's a bunch of ancillary tests you can do to also confirm. There's cerebral angiography. There's like transcranial Doppler, MRI, head CTs. There's SSEPs. There's EEGs, evoked potentials, SSEPs, which look at how anyway. These are a bunch of tests. I'm not going to get into the nitty gritty of. I'm just saying there are other tests you can do to also confirm brain death as an ancillary. But I will say that the clinical exam, the neurological exam, and the apnea test are sufficient to diagnose brain death. All right, so once the diagnosis of brain death is made, then organ donation. So there's different ways of donating organs. There's it's called donation after cardiac death, DCD donation. That's someone who's dies, and their body dies, and what this is like the patient dies, and then immediately, like, you stop care on the patient, whether that, extubating them or whatever, taking the breathing tube out, stopping their life support, and then you immediately take them to the operating room. They're pronounced dead, and then their organs are procured. That's DCD donation. So the problem with that, and that's donations are done that way. And I've been the physician that has been there and declared death, and told the surgeons to go ahead and start, harvest. Sorry, I look at that. I almost used the word harvest again. Again, I'm not going to edit it out because I just want to show that word is. Anyway, what was I going to say? I've been the physician that's been like, okay, go ahead and procure the organs. Again, I'm not making a brain death diagnosis. So I'm not contradicting myself, just so you're aware. I'm making this patient has died, and yes, now we can procure the organs. So that's DCD, or organ donation. The problem is you create ischemic time. As soon as a heart stops beating, the organs start to die. They don't have blood flow. So the surgeons are like lightning fast trying to get those organs out. So they're preserved, get them on ice, and get them to other patients. So DCD donation. So having a patient that is brain dead and their heart is still beating and their organs are still working, that is obviously preferable for procurement of organs, because the organs are still there and they're getting all the nutrients and whatever, the blood flow, all the oxygen that they need. So that's why organ donation from a brain dead donor is ideal to procure organs. And what you do, the patient's pronounced brain dead, the family says goodbye, and then that patient is then now a completely different set of team, now takes over care of the brain dead body, and then brings down the patient to the operating room. I've done the anesthesia for these patients. They still need anesthesia. These brain dead bodies still need anesthesia. And I get asked, oh, is that just because in case they're still alive? No, okay, because they're dead. They're brain dead. The reason is because they still have spinal reflexes, and they still have a heart that's beating, and they still have blood pressure. They still need a physician or an anesthetist, a care team, to make sure their blood pressure is fine, to administer paralytics, to even administer opiates, to calm down the reflexes, to stop the reflexes from moving, stop the patient, the body from moving, and a hand moving, an arm moving, and to keep the blood pressure and the heart rate within a good limit to preserve the organs until they are procured. That is the reason they still need the brain dead donor needs anesthesia. And the surgeon, the transplant surgeon, will make a determination, takes a look at all the organs, the lungs, and everything will be procured that is viable. The lungs, the heart, liver, kidneys, and more. And so that is brain death organ donation. That's what happens if the family decides that, or if the person was a organ donor beforehand. That's what can happen. Now families can say no, and that is their prerogative, of course. And then they're not a donor, or they may not be deemed a donor because the body was also in multi-organ failure and their organs don't work very well. But oftentimes, if a young person has traumatic brain injury, someone in their 20s or something, and they're an organ donor, and they have a trauma to their head, and they become brain dead, all of their organs are pristine, and all of their organs will go to save other people's lives. It is unbelievably bittersweet. And I will tell you my experience. Usually when I take a patient to the operating room, I leave with that patient from the operating room, and they're awake and they're safe and they're alive. It is a sobering feeling, because when I'm in the operating room with a brain dead body, where the surgeons have now harvested the organs, and they say we're done, the organs are procured, and we turn off the anesthesia machine, and we just walk out of the operating room without the patient. That's a weird feeling. That's a weird feeling right there. All right, I think I'll call it a day on talking about brain death. I hope this has been helpful. It is unbelievably confusing constantly, over and over again. And I'm not an expert on brain death. I would consider an expert on brain death someone who's a neurologist, and also a neurologist who's a critical care physician as well. I have many colleagues, and they're amazing people. So I'm not an expert on brain death by any means, but I hope this has been helpful. Please share this episode with people. Seriously, be like, do you want to learn about brain death? Just share this episode. People need to know what brain death is. It's a constant. Anytime I make a TikTok video about brain death, it gets hundreds of thousands of views because it's so controversial. Because people are like, whoa, I don't, it's unbelievable how controversial it is. So please share this episode with people. All right, let's move on to the next segment, which is talking about a book. The book today is Corruptible, Who Gets Power and How It Changes Us by Brian Klaas, Klaas. This was published in November of 2021. It's about 320 pages. I listened to the audiobook of this one. It was fantastic, the narration. So this book, wow, it's about who gets power. Why are people attracted to power? Is it the corrupt that's attracted to power, or is the power corrupt? That age-old thing. And this really does a good job of answering it. So with really highly accessible language, but really presented in a scholarly way, the author does an impeccable job laying out why leaders are corrupt and what to do about it. He's a political scientist who has clearly studied the topic and has interviewed scores of dictators across the globe. And he really aims to answer the question, does power corrupt, or are the corrupt attracted to power? The short answer is yes to both of those questions. And he really does a good job of explaining why, with a lot of anecdotes and research. He shows us that, yes, there are those with psychopathic, Machiavellian, and narcissistic tendencies. And yes, these people are attracted to positions of power and actively seek those positions. Once they're in place, these corrupt people leverage their power into doing all the corrupt things we know these people do, like consolidating their power, getting people to conform with them, ousting the dissenters, nepotism, exploitation, embezzlement, right? The list goes on. We know the playbook. The whole thing started when people started making projectile weapons. This is what the author argues. Before projectile weapons, power systems were diffusely distributed rather than being consolidated. Ranged weapons leveled the playing field, placing intellect over brute force. Power hierarchy is a relatively recent human phenomenon, as most prior power structures were flat. There's a trade-off because flat societies have a bit of a ceiling, where advancements and innovation become stagnant because every individual is doing the same things to survive. Once ranged weapons and surplus came along with agriculture, bam, now you've got power hierarchies happening and a corruption of those power systems. After the power hierarchy is set up, we have an evolutionary mismatch where our lizard brains may still believe that those with the most bravado, those that are usually in our society, Western society, are usually white men, are still the most equipped to be leaders, right? That's our primitive lizard brain that thinks that. This lends us to being manipulated and highly vulnerable to corrupt systems of governance. So yes, those that are corrupt are attracted to power. But Klaas, the author, reminds us that the systems matter. A corrupt system will unleash the corrupt and have a further corrupting influence on those that are in power, with a ton of examples. He shows us that if you make small changes within a system, you can quickly weed out corruption. And rather than setting up systems of surveillance for those that are controlled, we should surveil those that are actually in power. We should make leaders second guess their decisions and have them never know if they are being watched, not the citizenry, right? Recruitment is the key solution. Recruitment into leadership. We need to attract people to powerful positions that don't actually want to be in power. We all know those are the types of people that make the best leaders. Just think of your favorite, boss, which is a stupid, I hate the word boss, but, people that you admire as leaders. These are not people that want to be leaders, unless you're the type of person that is attracted to authoritarian rule. So anyway, so these are highly likely to be incorruptible, people that don't want to be in power. Rather than looking at wins and losses, we should scrutinize the decision that was made before a good or bad outcome. We should focus on how good results came about just as much as bad results. Or we may be punitive to good leaders and reward those that are actually corrupt. Anyway, very, very good read. It was eye-opening, worthwhile. I highly recommend it. Again, it's called Corruptible, Who Gets Power and How It Changes Us by Brian Klaas, Klaas. All right, I'm going to answer a question. This is sent to my email, which my email is icudreckmo@gmail.com. This email was sent by Bailey, who sent me a very lovely note about the podcast, and she really enjoys it. Bailey, I do appreciate your email very much. And then she has a specific question. What has been one of your proudest moments as a physician that sticks out the most to you when you reflect back? That's a good question. Okay, so I stepped away and kind of thought about this for like a day. My initial response was doing like a cool procedure for the first time or something like that. But I don't know if those were proud moments. They were just kind of like, oh, that was cool. So there's many answers I could have for this, but I think here's the one that came to my mind the most. During the height of Delta and Omicron surge, where we had lots of COVID patients that we were putting on ECMO, which I took care of a lot of these patients. There would come a time when they're on ECMO and they didn't have any lung recovery where these patients, there was no reason to keep going. And that's a very hard thing to talk to families about. So I was coming on to the service I'm usually on a week on at a time. So there's some good continuity of care. Where I'm at, it's like 12-hour shifts, and we do 12 days straight. Sorry, 12-hour shifts, 7 days straight. Anyway, so there was there was a patient with COVID who had been on ECMO for probably 60, 70 days. And I had taken care of the patient prior, right? Because when I was on the service. And I was getting sign out from my colleague who was like, we're trying to really talk to the family about that this isn't the right thing to do for the patient to continue ECMO because there's no reason, because the lungs aren't recovering, the patient's not a transplant candidate, and it also has like kidney failure and things like that. So anyway, so I'm coming back on the service, and my approach like this, when I come on a service and I know that this is the situation where it is my belief that the best thing for the patient is to stop supporting their life. And it's not just mine, right? It's like all healthcare workers, but the family is still not on board with that, which I understand. It's not like I'm not like placing judgment on them. I get it. I understand the hesitancy. I get it. But my approach to this family and what I've learned is being extremely transparent and telling them what, anyway, so I met this family and I was like, I know that this family had been hammered by all staff to stop care. And so they had heard it a million times. So there's no reason to keep reiterating that over and over and over again. In fact, it becomes a point where it's totally counterproductive. And so when I met with this family on Monday, and I just expressed that this is I want to do exactly what's right for the patient, and we all know what we want, and we want the patient to live and to leave the hospital. That's what we want. But we're in a situation where that won't happen. And I basically was like, it is your decision. I trust you to do what is best for this patient. My agenda is to do what's best for this patient. I will do exactly what you want. And I kept it very brief, and I was very transparent, very open with the patient's family. And the next day, they were done, and we stopped care, and the patient, and we stopped ECMO and removed the ECMO from the patient. So the reason I'm proud of that is because that's an extremely challenging situation, and it takes a lot of like nuance. It takes a lot of developing rapport and trust with a patient's family to achieve something like that. So I was very proud that I was able to open a dialogue with the patient's family and to get their trust it wasn't just me coming in, right? This is weeks and weeks of different people talking, and this is dozens and dozens and hundreds of people that have cared for this patient to get the patient to this point. But I was able to just make that final nudge by just backing away from them, so they can maybe give them some perspective about what the situation really had become. And that was the best thing for that patient. That patient passed away immediately because the patient's lungs were destroyed. So I'm actually very proud when I am able to achieve that with my team that I work with, where we arrive, with the patient's family, where we get there. Anyway, so I think that's it for today. I'm going to take a break, probably a 4 to 5 week break of making podcasts. So this will be the end of season 1, I guess. I think it'll be a 4 to 5 week break, and then I'll start back season 2. Share the podcast, etc. If you're into it. Getting a lot of good emails of people that are enjoying it. So I'll keep doing it. My email is ICU. What is it? ICU doctor. Wait, I forgot. Okay, yeah, it's ICU doctor ECMO @gmail.com. My TikTok is ICU doctor. Instagram is ICU doctor TikTok. So yeah, send me emails, send me questions and stuff. I'll answer them. And thanks for listening. But yeah, I'll take a little break and I'll record, batch some here and there, and be back with new episodes in about a month. So yeah, thanks for listening, and share and write a review. Have a good one. Thanks.